Hello. Good evening. Welcome. So let me try that again. Welcome. My name is Shali Prasad. I'm the Executive Director for the Center for Global Health and Social Responsibility here at the University of Minnesota. And it's my privilege today to invite you all to this special event. Before we move further, I have a special thanks to Dr. Sam Na. Sam has been our main contact with Dr. Mong and has been able to get her here. Thank you for all the rather hurried arrangements we did to get her here. Just a quick mention about our center. Our center sits across the health sciences schools, but we work across the whole University of Minnesota. And our job is to actually catalyze socially responsible global health activities across the University of Minnesota. We do this by stimulating conversations, starting projects, providing seed grants and travel grants to faculty all over the world. A particular area of interest has been in East Africa, particularly around Uganda, and we have a huge presence in Southeast Asia. This might surprise you, but the University of Minnesota has a pretty big global health footprint, partly because we have a pretty large health sciences faculty. Cutting across all 6 disciplines, we are one of the few universities in the country that have 6 health sciences disciplines. Currently, there's a pretty large One Health workforce grant sitting with the College of Veterinary Medicine that is involved with training of health providers, particularly in zoonotic diseases, all across Southeast Asia and East Africa. If you have any more questions about our center, please reach out. I have a bunch of my staff here. Amy is back there. Or please visit our website. Just do a Google search for the Center for Global Health and Social Responsibility. It's quite a big name, but we are the only one with that big name on Google, okay? I also want to do a quick pitch on one of the particular activities that we're involved in refugee health. We work with the United Nations International Organization for Migration, also known as IOM, which is headquartered in New York City, but conducts and pretty much runs all the refugee camps around the world. And our work with them includes capacity building, training of their providers. We do this by training the providers either here in Minnesota, we fly the providers here to provide that, or in various venues around the world. This has been a very fruitful partnership, and we just met with the CDC and IOM last week, 2 weeks ago. They were talking about this is the only such model that they've ever known to work, where we bring in the expertise of the university, the practical know-how of the International Organization of Migration, and the power of the CDC to do the training. We are hoping that this particular activity of ours will lead on to further activities in refugee health. The University of Minnesota has a huge history of refugee health. The state of Minnesota has a huge history in refugee health, and the Minnesota Department of Health, I would say, is the best Department of Health as far as refugee and immigrant health is concerned. Now, it's my privilege to introduce Dr. Cynthia Mong. Thank you for coming. Dr. Mong is a founder and director of the Mae Tao Clinic in Mae Sot, Thailand, that provides free healthcare for refugees, migrant workers, and others in need, particularly the ones who cross the border from Burma to Thailand. She's a Karen physician who trained in Yangon, Myanmar, but had to flee during the 1988 conflicts and has been working in Mae Sot since then. She initially started a very small clinic that's grown into a pretty large setup. I know many in the audience have visited her clinic, and I've heard really good stories of it. It has both an inpatient and an outpatient center, and provides a wide variety of health services, approximately to about 150,000 people, and their annual consultations of about 100,000 patients. Dr. Mong has an extensive bio. I would strongly recommend you Google her. Multiple prizes all over, but what brings her to the US this particular time is that she's a recipient of the 2018 ROUX, R-O-U-X award from the Institute of Health Metrics and Evaluation, and we used that as an opportunity to invite her to Minnesota. Dr. Mong?
Good evening, everybody. It is our great pleasure for us to be here, especially this time while we are together to learn from you and to learn from me about the global health, human rights, as well as since you are also working with the refugees, migrants in the United States, we have a sharing of the similar story and population displacement along the displacement in the issue of the global health and human rights area. So it is great pleasure for me and my colleagues to be here to tell the story and to raise awareness about the border situation as much as possible. So as you may already aware that we come from the Thailand-Myanmar border, and this Thailand-Burma border is a very long border sharing 5 districts in Thailand side and also different ethnic states in Burma side. And all along the border we have different refugees fleeing to Thailand since 1984, and many migrants and refugees are moving back and forth because of the conflicts and because of human rights violation, poverty, and also there is ongoing some natural disaster, environmental deterioration. So many people moving back and forth for accessing healthcare, education, opportunity for job and livelihoods. So the population are very mobile, and also they're moving back and forth the whole border area. So among those, there are 3 groups of population we can identify. The first group are who displaced into Thailand and living in the refugee camp. So the whole border, there are refugee camp in the northern area, 2 refugee camp in the Karenni, and in the Tak province, we have 3 refugee camp. Also in the southern area, another 2 refugee camps. So there are almost 100,000 refugees are living on the border right now. So many refugees has been resettled to United States since 2004. So you may be aware that there are almost 20,000 Karen and other Burmese ethnic refugees resettled to Minnesota. And another group of refugees are who don't need to cross, who continue seeking care and support in their own community. They don't want to move, or they continue living in the jungle. So these are we call internally displaced people. So along the border, almost 500,000 of internally displaced people are still living in Eastern Burma. And there are many other refugees who could not access to the refugee camp, or many migrant workers who displaced from the human rights or poverty. So there are almost 300,000 Burmese refugees living in the Tak province. But the whole Thailand, they are living in the whole Thailand as a migrant labor. So today there are almost 3 million Burmese migrant workers living and working in Thailand. And since Mae Sao is very close to the border area, and there are many other political exile groups who are living, working, and they are seeking like a temporary asylum in Thailand side as well. Sorry. So when I would like to start telling the story about Mad Dog Clinic. So the name Mad Dog Clinic is given by the local Thai community because the clinic is situated in the village called Mad Dog. But actually the clinic hasn't been setting up as a registered medical center because of there is a lot of migrant workers, refugees fleeing to Thailand. So access to healthcare in Thailand is very challenging for them because they are undocumented. So since we start provide service for this migrant and displaced population, the clinic is considered as a health center and is supported by Thai government and Thai public health. So when we arrived to Thailand in 1988, we have to cross through the border. It takes almost 7 days from the village, our home village, to the border area because of in 1988, when the Burmese government cracked down the pro-democracy movement, thousands of Burmese students and refugees crossing the border into Thailand or living in the jungle as a refugee status. But in the initial stage, there are many students and young people coming from the city. This is the first time for them living in the jungle. So this is very difficult situation, but among those are teacher, nurses, health worker, lawyer. So as soon as we arrive to the border, the local community, with the support from the local Karen community and local Thai community, we able to set up a community health center or able to set up a library. And among those are many displaced young children. So the teacher also provide child protection education. So the people who displaced to the border or to Thailand do not consider themselves as the refugees. They are also the community the community leaders, or they want to make or contribute the benefit for their people and to use their skill and knowledge. So since that time, the community organization has been growing on the border. So in the beginning, most of our patients we see at the clinic are war casualties and malaria and the mental health problem, because many people have witnessed their friends and family members being tortured, and some of their friends are in the prison, and also some of them they fled on the way they fled to Thailand. Their friends were killed during the fighting, or the friends were died during like a malaria endemic area. And they also see that many current villagers and the community members are displaced in the jungle. So many of them being traumatized. They witnessing many problems and suffering. And at the same time, Burma border, Thailand border is one of the highest malaria infested area. So many students also student and civilian, the new arrival, they've been killed by malaria. So many of them, they suffer from malaria and mental health problem. And initially, we only have very small facility, and there is a small room for the surgical department, and one of the young student who got injury during the fighting or during displays. So in 1998, we start seeing one of the volunteer coming to the border, and since that time we have many international volunteers coming to us, and we start able to establish a small health facility over there. So the clinic also become a small training center for health workers, because we are very few. There were only few health workers on the border area, but there are lots of people who displaced during the war and who could not access to healthcare. So the clinic start training local community member to become as a health worker and to provide care and support for the village. So the mobile medical team has been established since that time, and this reached to many displaced population on the border. So on the border at that time, there is no international NGOs access to this border area, and so most of the services and most of the training of the health worker have to do through cross-border. All the training program is based in Thailand, and then the ethnic community, they cross the border and they come and get training as a midwife and nurse and doctor, and then they go back to their own village working with the community. So since that time, the health program and the mobile medical team program been growing on the border area. So as you may see this photo, this was taken in 1997 when one of the refugee camp was burnt by the armed groups, the military. So during that time, all the refugee camps, the people are very afraid of all the atrocity. And then one of the international NGOs start working with the children. So they start working with the children and they cannot tell the story, but they can draw. So as you may see that the children experience in the war where they crossing the border, what is happening to their family and their friends. And also they have experienced their village being burned down. So these are all drawn by the children during 1997. So gradually, we start seeing more patients who crossing the border from Burma into Thailand, because at that time, the Burma economic situation deteriorating, and more migrant refugees come to Thailand. So we have seen that initially we only have outpatient clinic, and the hospital in Thailand start helping us to establish antenatal care, family planning. At that time, we don't have inpatient facility. So many women deliver at home, whether they are in the Eastern Burma part or they are in Thailand. So most of the delivery happen at home. When they see the problem, it is very hard for them to travel, like long working hours, or sometimes the checkpoint prevent them to cross the border. And some of those who are living in Thailand also, they have problem at night time. There is no transport system, and they cannot afford to pay for the medical services. So since that time, we start seeing more pregnant women need care and support. So we start setting up a maternity unit. So this is the first group of women we bring from Karen State to Thailand for delivery, because they are high-risk pregnancy. We identify that. And then at that time, we start train the community midwife and train the midwife in Karen State so that women can deliver safely, and setting up the referral system to Thailand or to the nearest hospital. So maternal child health program had been started since 1995. And the training program in the village also started. Many young midwife, they also reach to the different community and train the midwife with the very limited resources, like wearing the gloves or hygiene practice, and also referral system. So since that time, our maternal child health program been expanding, and many women can access safe delivery at home. So gradually, our health service program expanding to the social service as well, because many people who come and access services have many other issues, not only medical problems. And we see that children with severe malnutrition, and they come again and again, even they were discharged from the hospital, they come back again because lack of proper knowledge and mobile population, as well as they don't have the regular job. So on the border, malnutrition is one of the challenge area we have seen. So we have to start program for the food nutrition promotion program, as well as we see that many people who got injured in the war zone, and they don't have enough facility to get the prosthetic and rehabilitation program. So between 2000 and 2010, we expand our service for child nutrition, child protection, and prosthetic workshop. So this graph will show about number of babies who were born at the clinic over since 2009. Actually, our clinic deliver baby started in 1999, started in 1989. But before 2009, the children who were born in Thailand without birth registration, birth document, even we provide safe delivery home or hospital, and the parents doesn't have legal documents living in Thailand, so they could not go to the Thai hospital. They could not afford to pay for that, so they come to our clinic. We operate our facility, but we could not issue the Thai government not issue the official delivery certificate. But in 2000, starting from 2008-9, the Thai government start issue delivery certificate for that baby. So the clinic program been expanding. So not only deliver baby, also we have to set up a program to send the children to get the official birth certificate. Actually, the children who were born in Thailand today, almost 90% they can access birth registration, but this have to be within 15 days. If they go and inform after 15 days, it's become more complicated. You need a document for the employer, or you need village head leader signature, and you have to prove this is the parents, the proof to be parents. So it's more complicated, and sometimes the office being closed. So that means that in the holiday, so some children could not be registered. But being registered as a Thai official certificate means they did not become the Thai citizen, or did not guarantee for become the Burmese citizen. Because since the parents doesn't have legal document, and even some parents doesn't have Burmese citizen card. So this is challenging for the population, because children or adults in the 2 or 3 generation who were born in Thailand or Burma side doesn't have the proper document to become as a Burmese or Thai citizen. So until now, we will see that the situation has some changes inside Burma, mean like the political situation has been changed, and we already in 2010, the election, the first election, with the government, like a civilian government, but access to healthcare for the people on the border is still very challenging. As you may see that both in Eastern Burma and Thailand, different kind of barrier like financial, and people don't access to healthcare because they don't know their rights, and geographic like remoteness or lack of social infrastructure. And many patients coming from inside Burma, they are different ethnic, they use different ethnic language. In Thailand, Thailand also not all the health center doesn't have interpreter, so the language barrier is the issue. And sometimes because of the lack of good transportation system, so people cannot come to the clinic on time. So there are still many barriers for accessing healthcare. So since the clinic growing, we see increasing number of patients. This is one of the busy day at the clinic when people start arriving to the clinic in the morning. Yeah, so this one of the photo when we start expanding our maternal child health work. So many children deliver at the hospital or in the clinic safely. So today our clinic have almost 250 health workers, including midwife, nurse, and we have 2 clinical consultants, international volunteers, and we also have a school, and we have also school and child protection services. But for the healthcare services, the number of patients who we see is gradually declining after ceasefire in Burma, because we also try to improve access to health service inside Burma through training of the midwife. So today, last year in 2017, we have almost 50,000 clients, and some of them come for 2 visits, 3 visits. So the total visit is about 100,000, but the total client number who access to our service is 50,000, and almost like 46% patient who stay coming from Burma into Thailand for accessing healthcare, and women and children make out of the higher proportion in our services. And we have currently 160 beds, and also we have the bed occupancy rate is still very high, 75% bed occupancy rate. And children are provided care and support. So through our program, we provide food and nutrition for the children, and we provide a school health program for almost 7,000 children on both sides of the border. So currently in Thailand side, we partner with local Thai government or university or the foundation, because the clinic, since the beginning, the clinic could not be registered as a clinic or hospital, because all the health workers who've been trained on the border and using the standard protocol guideline curriculum, but this certificate is not accredited and could not get the medical license on both sides of the border. So, but the Thailand government has been providing support to us, because many migrant refugees who don't have legal documents could not access to the Thai government. So through the international NGO network or through the civil society network like Metal Clinic, we able to provide service. So for us to be able to access more legal service support, we have a foundation working in Thailand, like we call Suvarnamit Foundation, and also the Ministry of Health in Thailand also provide us support for immunization, school health promotion, as well as like a disease control area. And we also work with university in Thailand, the Masai University, for health worker to study public health and to learn about the border health issue. So the certificate program being set up with the university in Thailand, as well as like health management, health system management, health facility management course being set up working together with the university in Thailand. So this Thailand side is also one of the area we try to upgrade the health worker and health workforce for the Eastern Burma. And since Burma changed the political situation, we work with different ethnic health organizations to strengthen the health system in the Eastern Burma. So the health system strengthening project has been established. It's a network of local community and ethnic health organizations to help strengthen the health system for the ethnic community and to improve access to the quality healthcare services for displaced population. And we work with both local, regional, and international organizations to approach like a comprehensive approach to the healthcare service for those people. So the health system strengthening working group, together with the ethnic health organization, is using the model for health system ownership by the local community. So this is part of the integral part of the federal health system that the ethnic groups has been demanding for the federal and like a self-determination, because the health system in Burma is highly centralized. So all the financial and administrative power being controlled by the central government. So there has been no local or district or state level authority the state level authority only have the coordination role. So the ethnic health and the civil society trying to advocate for the decentralized health system so that people can access more equitable and essential health service in their own community. So in the health system strengthening working group, one of the pillars is we do the health information management. So every 4 years, the ethnic health organization and the border community being collected systematically the health information in the population level. So as you may see that the Eastern Burma health data is much worse than the national figure, and also compared to Thailand, it is, you can see that a big challenge or a big suffering of the people. You can see that. So our infant mortality rate, under 5 mortality rate or maternal mortality rate is much higher than the national figure. So that means the displaced and migrant population, we have been treating and seeing different cases, but this information has been not showing in the national figure, whether they are migrants or refugees or internally displaced. So the government data in Thailand or Burma doesn't show this data. So we are become one of the worst health records in the region, as well as like compared to the other conflicts and wars. So through the health information system working group, we're looking at 6 building blocks that has been the strategy for WHO for rebuilding the health system in the community. So to improve access and coverage, and to improve the quality of the service, and to provide safety and dignity of the health service for people. So we need to build the 6 building blocks. This is essential, very essential part of the building health system. This includes service delivery and workforce, and then information management, medical products, and the financing, and also the leadership and governance and the structure of the health system, so that the people can access health services more equitable, and then we can monitor the services and respond to the needs of the community, and also the risks of the financial burden or the risks of the social being protected, and then to improve efficiency of the services we provide for the vulnerable population. So why we have to build, we're saying about the providing service and as well as the building the system, because over the past years, the clinic and the health worker on the border are service provider and the managing the program. But we have to now, with the change in the political context, we have to start building the system, health system. So that means all the people in Burma, regardless of the ethnicity or regardless of the geographic remoteness, and they have to need to able to access equitable health services. And before the ceasefire, the Karen and many ethnic community, they've been setting up the health system in their own community. And also they have to, they feel that even they are living in the refugee camp or Thailand or working in the conflict zone. And gradually when the country rebuild, they can be the key health service provider for their own community. So building the system means the community initiate the health program in their own community, and they've been self-managed, and then also all the language, culture, and need to be engaged in the health system. And then in the primary healthcare services, we provide not only the curated service, also health promotion, water sanitation is an essential part of the healthcare. And to improve the health system, also training and standardization is very important part. So currently all the ethnic health workers getting the standard training curriculum and the standard protocol and guideline. And
closer to the microphone.
And then health policy development is one of the key area for the ethnic groups, because the health policy need to be make sure that this being ensure the universal health coverage for all the people, regardless of the status or regardless of the geographic area. So it is a very essential part of the building health system through the policy development. So as you may see that during the conflict time, our health workers who are working in the jungle, they have to face great challenge about medical services. This is one of the photos showing about the referral system. And when you see about the referral system, we don't have road and ambulance, or so people have to carry 3 or 4 days to reach to the referral place. So that's why the local community organization is the key provider. So including the specialized service like trauma management, landmine awareness, and family planning, providing birth records to the children. So we need to make comprehensive health care services for that. And also on the border, there are many international NGOs working in different camps or many ethnic organizations. So we have to start looking at all the common disease illnesses and have to have the standardized medical records and standard treatment protocol across the border. So today in the Eastern Burma, we work with 8 ethnic health organizations, and these are all the region and state access services through our network. So we have different ethnic organizations listed here, like Mon, Karen, Karenni, and Backpack Health Worker Team BMA. So altogether, our access population is almost 700,000 people. And the total health center or team is we have 240. So mostly the ethnic groups are living on the border area. So most of the population we assess are in the border region. So this photo showing some of the home-based care and family planning counseling in the village level. So in the health system strengthening working group, we also start working with Ministry of Health in Myanmar, especially for training of the midwife and standard curriculum and performance for midwife, because midwife is an essential part of the health workforce. In Burma, midwife do everything like vaccination and delivery, antenatal care, family planning, but their workload is overwhelming. So our midwife also specifically trained for maternal child health, including neonatal care and emergency obstetrics. So we want our midwife to be able to get the official certificate working as a midwife in Burma, because until now the health worker who were trained on the border hasn't been get any official certificate, whether in Thailand or Burma. So this is very important that when the refugees return to their home or return going back and working in the health care, so they need to be accredited and certified as a health worker. And also we advocate for decentralized health system to recognize the existing ethnic health infrastructure. So until now, there has been the ceasefire talk going on, but there has been not much things happening on health system approach, because the ethnic health infrastructure hasn't been officially recognized by Burmese government yet. So we need to continue working with the community leaders and community organization and the local local district health department to work together and to engage with the ethnic health organization. So we still have challenges continue in Burma and Thailand side. Even there is some political change going on, the population displacement is happening ongoingly because of poverty and environmental deterioration. So people continue crossing the border into Thailand for accessing healthcare and finding better job opportunity. And also many children don't get official birth certificate. So these are ongoing challenge for us. So we need to, the civil society group, continue advocate for child protection service, improving the referral system, and recognition of the existing health, education, and infrastructure of the ethnic groups. And also many people still cannot afford for healthcare service because we don't have functioning health insurance system in Burma yet. And many migrant workers also cannot afford to buy insurance, especially for women, children. So if they go to the hospital, the cost for medical care or out of pocket is almost 80%. So people cannot still afford to pay for the healthcare service. So there's need to be ongoing advocacy work for us to ensure that people access universal health coverage for the whole country. But for the Burma government now, with the universal health coverage goal is 2030, so it will take time to rebuild the health system in Burma. So for us, we continue advocate for health as a basic human rights, and also health is being determined by many social factors like the community cohesion, because in the displaced community and ongoing displacement and not undocumented, so how people can improve access to healthcare is very important area, especially when young people displaced from their home. There is lack of awareness on the different community culture and also the language barrier and also the livelihoods and working condition in their home or in the community in Thailand is very poor. So this ongoing need advocate for social protection as well as the environment they live. There is need more protection for children, women, and also need strengthen network for the referral services. So we need to continue advocate for all these social determinants on health. So our clinic become like a integral, like a children, women protection is become integral part of our health care services, because many women also suffer from like gender-based violence, unplanned pregnancy, unsafe abortion. Also children suffer from abandoned children. We see that abandoned children is also a huge problem in Thailand as well. So many Burmese migrants and refugees who separated from their home need continued support from both in the local and international network. So for Med-Doc Clinic, we will continue provide healthcare, education, and also services for children and women. These are the key area we continue provide. Also in Burma side, to be able to improve access, we will continue train midwife and volunteer, community volunteer, public health worker, and also with the goal of the universal health coverage 2030, we will also try to engage with the Ministry of Health in Burma and different ethnic health community. So there is very important that both Thailand and Burmese government to look at the health services and health program, not looking as not only in the national issue as a border issue, because the border is very unique. People are not counted, not listed, and not documented. So the national figure or national health plan sometimes deny of this undocumented and mobile population. So we need to continue advocate and working with closely with the government on both sides of the border, and need to continue provide safe delivery service and child protection education service. And also, since many people who displaced from their home suffer from trauma, so this need to be a strong support network for community to make sure that people get counseling service and rehabilitation program, and also to make sure that children psychosocial support is very important part of the rebuilding the community or rebuilding the country. So thank you for your, it's a little bit long, but I think it is very brief. But if you have more questions, please. Thank you.
We are recording tonight, so if you have questions, we'll come around with microphones so your question could be captured in the video. So raise your hand. Thank you.
In Minnesota, with refugee groups, we have so much trauma, children's trauma. The Hmong kids, they were never dealt with their mental health issues, just pushed into schools. So I'm wondering your trauma management and what suggestions do you have that we can tackle globally this huge trauma among the children?
So on the border or in Burma, before trauma or mental health is one of the neglected area because people are suffering from like communicable disease or reproductive health or war casualty. So trauma is not priority area in both in the camp or in the community in Burma. And also mental health is like a stigmatized issue like HIV or STI or TB cases. But gradually, like starting from 1999, we start working with the Filipinos group and South African mental health group and the Boston group. So since that time, people become more aware on mental health and trauma counseling program. But it is very challenging because there are many different issues like gender-based violence and child protection area, child abuse, and ongoing displacement and lack of food and job opportunity, especially for children and adolescents. It is very hard for them to make a space for healing. But for us, we feel that the school and health center have to become the counseling or healing or community center. Because through our health program or school, the parents and children and teacher come together to share more about their concern and to open their concern or feeling. So we need all the health worker trainee and teacher trainee need to include the trauma counseling. But we also need the special like treatment or referral system. But until now, very limited and very hard for the treatment center because in Burma also we have very few counselor under the government system, also very few mental health worker. And in Thailand side also, in the past, we have to refer to the tertiary level or other province. So mental health treatment is not easily accessible. And gradually now, all the health workers, they learn basic counseling and the mental health. And in the community, also start identify the community leaders or teacher or health worker who are really engaging with the community health and the socially or culturally appropriate approach. So it is still a very difficult time, but I think through the education program in the school or in the health center, this need to be integrated, all the mental health issue. The same time, all the social worker, teacher, health worker themselves, people are already traumatized. They have their own bad experience. Sometimes people don't want to talk about that. But you need to have a community to support and to reduce the stigmatization, as well as to give more opportunity to open their feeling and concern and the other recreation activities, including the trust building, because people have been under the oppression for many years, so they don't want to open about all the feeling, and sometimes trust is also part of the healing, wound healing. But I think it is still very difficult in the country because people under the military oppression or people are under the different dividing different community geographically. So people are suspicious under the military rule. So until now, trust building and the community rebuilding is one of the challenging area we have to face, especially when you see about reconciliation of the country. So we have to start from the beginning since they were very young in the primary school level or kindergarten. So how they start feeling about what is about human rights and discrimination and the caring for each other and making the social network, it is very important part for us. But when you are displaced or you become like doesn't have legal documents, so this may continue oppression to their life. So it is very difficult, but people become more aware and more talking about the mental health and engaging with the mental health program.
So I'm Brett Hendel Patterson. I work in global medicine at the University of Minnesota, and I had the good fortune to visit the Maytao Clinic with some of the Dr. Hoffman, some of the other University of Minnesota faculty. And I just want to call out what an amazing and inspiring healthcare system that you've put together. I think all of us who went have been working in global health for a number of years, and your work at the Maytao Clinic is absolutely amazing, working with an incredibly vulnerable population, and even having done work in global health for 15 years, the challenges that you face with, some of your patients being almost without a state, highly mobile and difficult to track down. I just would like to say that we all came away very impressed with the combination of the clinical care that you deliver in very challenging situations, the education that you provide to really provide health, training, and also things like even housing for people that are coming into your clinic, and to hear about the advocacy you're doing as well. Your work is absolutely inspiring and amazing. So thank you for being here and sharing it with us.
Yeah, actually, we are proud of being the community organization because since the border is very unique, we are also good opportunity to work with both Thailand and Burmese, like a civil society group. We learn from each other. The Thai civil society or the Thai human rights group also, they become more aware on the Burma situation. At the same time, the Burmese civil society group strengthen the network with the Thai civil society. So we feel proud of that because the people who are living on the border or even they are like refugees, migrants, they're able to establish a strong network of civil society organization on both sides of the border. And also we work with diverse ethnic group. So there has been not much connection and networking before, but the civil society group been growing over the past 20 years, like women organization, youth organization, health organization. But we very much proud that all the civil society group also working together on improving health, education, and protection service for this vulnerable population.
Hi, thank you so much for the presentation. My name is Baivu. I'm with Salamo at Westside Community Health Center here in St. Paul. If I remember correctly, one of your PowerPoint slide talked about the importance of the government recognizing some community health initiatives. What do you think would take for the government to recognize these initiatives and financially support them?
So firstly, the government needs to recognize the existing or strong network of the community organization working with the displaced and refugees over the past 30 years. And then they need to recognize that the refugees and migrant workers, when they return to their country, it not only going back as the ordinary person, there are a lot of skill and knowledge and certificate they receive. So, when they return to their home, they need to be recognized as a citizen, and they need to recognize as a skilled health provider, and they need to be recognized a growing civil society group. And the third point is the conflicts in Burma need to recognize that we have diverse ethnic group. So to be able to provide efficient and quality service for all and equal health services, need to empower the different ethnic organization or civil society group working in the region. So that means the decentralized health system, or also providing more empowerment and opportunity for the local community. So these are very important, that this is a basic human rights and also the social, cultural, economic rights for the vulnerable population. So if the government, the central government control all the economic or administration, or this doesn't work for the local community, not appropriate, not engaging with the local community organization, the service cannot be provided efficiently. So that we need to continue advocate for the government. In Thailand side, even we are not registered organization, the Thai government also recognized that many healthcare providers are Burmese ethnic and refugees themselves. They have to help each other, and they can build the health service and system. So wherever in Burma side also, like the civil society is growing now, and they are asking or demanding for the basic human rights and engaging with the political process. So the government need to provide more space for civil society organization and ethnic organization to be able to rebuild the country efficiently.
My name is Al Emerson, and I actually passed Cynthia Ships in the Night. I just returned from Mae Sot a few weeks ago, and the complexity of the political situation that she faces there and the delicacy of which she has to manage is beyond comprehension for many of us over here who actually experience some form of government that isn't based on absolute and basic corruption. The two juntas are both in Thailand and in Myanmar are cooperating, but not on basic human rights. So it's a very delicate situation that she has to face over there. Much of what is going on with the Rohingya has actually happened to her to the Karen and the Karenni over many years. It's just a continuation of the similar processes. So she is a consummate politician to be able to handle what's going on over there.
I wanted to know how we could help.
Firstly, we need to learn to help the Burmese or Korean community need to learn the history of Burma, because one of the major generals say that forget about the past and we will move forward. But without knowing the history of Burma, I think very difficult to engage with the ethnic community and the civil society group, because since Burma has been under the oppression many years, people have been traumatized. Building the trust in the community is very important. But we have to acknowledge that what happened with the community or what happened with the, like under the oppression, how people have been suffer. So people can get more information through working with the different civil society group, as well as learning about the Burma politics is very complex. But without learning the politics, you cannot reach much to the solution. At the same time, to empower the civil society group to become the leaders, because the young people will become the leader for the future. So learning about the politics as well as building the system through the education is very important. And that's why we do health education protection and comprehensively. And for the international community, when they want to help the Korean or Burmese situation, learning about the local situation as well as building the capacity of the local community organization and local community leaders, so that people can understand both the human rights perspective as well as the political solution. So to be long-lasting, the peace, to build the peace, we need to get people to empower, to talk about their own story, as well as to make sure that this human rights violation will not happen again and again. So like people asking about what is happening with the Korean Mon or Rohingya. So people will not forget about that, but people have to learn how to encourage or empower people, as well as to make sure that this will not happen again and again. So the counseling may not only working with the local community who suffer, also the people who make mistake or the people who oppressed the country. So it is very important that to provide service is very important, but through providing the services, we need to build the system and the policy that make people feel that inclusive and equitable service being provided for all. So then you can build the trust of the people and you can support more people to engage with your mission.
Hi, thanks so much for your presentation. It's really an honor to hear you speak. My name is Marley and I work with the American Refugee Committee. And we worked for many years in the camps on the Thai side of the border. But a few years ago, we phased out our work there. There was this shift in funding and they were consolidating, implementing partners, I think with the idea that they would eventually phase out the refugee program. I'm curious, being there on the ground, do you see any sort of voluntary returns happening? Do people feel it's safe to go home? Is that happening, or what's your thought on that?
Voluntary return mean people feel satisfied or safe to go home. So mean that you need to have your own community to build in their own community or original area. But people feel that there has been not much livelihoods opportunity there. And the second thing is the ceasefire process is continue going on, but there is a lot of mixed administration, and the militarization is ongoing. and many like growing concern about the young people engaging with like the drugs and alcohol, and so people in the refugee camps getting more and more worried about the future when they return home. What is the rule of law, administration system, and the conflicts between ethnic organization and the Burmese army, and also the worry about their livelihoods opportunity because they want to return home, but their original land being confiscated or everything has gone. So people start seeing that they start return and see their situation there, but they don't think that it's not the time to return safely. So sometimes people coming back and forth, but also they try to find opportunity to go, and because in the camp also less and less support coming. So a lot of mental health problems, and also access to healthcare in Thailand also getting more and more difficult, especially for long-term care like HIV, TB. So I think it is very hard time for the refugees whether they should go back home or they continue stay in the camp, or they should go outside working as a undocumented or illegal migrant worker. So it is very a lot of like a stress in the camp.
Hi, Dr. Cynthia. My name's Erin. I work at the University of Minnesota and was also with the group that visited your clinic in August. My question is, given all of the struggles and the challenges that your staff see on a day-to-day basis, what motivates you and your staff each day to continue to do this work, and what gives you hope for the future for your patients?
The community organization on the border also facing a big challenge about the turnover of the staff because of like over the past 20 years, we have like resettlement programs started. So many health worker, skilled health worker or teacher resettle. And then some of the teacher health worker also, they want to go back to their original land, but there is no opportunity. So they start, there is no recognized as a health worker in their village. So they cannot go back home, but with the family issue or the children education not secure, so they start moving to other place. So other place mean like to the place where they feel that more like working as a migrant worker or moving back to their original like place where the parents can stay with the family. But it is difficult time for the health worker, teacher, social worker. That's why when we say about the mental health counseling program, it is not only target for the community, also the community leaders and also the social worker, teacher also need support to make sure that they are the leaders of the community, and they have to make sure that they can continue provide service for this vulnerable population, and access to further education or access to the information from the like national level or in the country level. So we need to have more networking inside, outside, so to make sure that people feel that they are the key providers, as well as we have to continue advocate for the issue about displacement, refugees, migrant workers, stateless people, so that people continue motivate to continue working as a provider, as well as advocate for human rights and also ethnic rights.
Thank you, Dr. Mong.
Thank you. So thank you very much, and also we feel very privileged to be here to share about the situation on the border and to make a stronger network with both local and international level, and to feel that we are part of the community to support and to continue working with the refugees on the border. So you have a lot of things already done for the current or many refugees resettle from Laos or Thailand. And at the same time, you may see that there are still a lot of issue and problem happening in our country. So please make sure that you keep in touch with the situation on the border as well as for Burma situation. Thank you.
Thank you. I just to continue with this theme, I just want to do a quick plug for an event we're having on November 5th. It's our annual Qui Peterson lecture. The speaker is Larry Gostin, who is a preeminent scholar in human rights and law. And he'll be talking about imagining global health from a social justice lens. That'll be on November 5th. Please RSVP, seats are limited. It's going to be at the McNamara Alumni Center in the evening. Thank you all for coming. Please look us up if you have any questions.